Okay guys, tonight we're going to talk about diabetes. Alright, so we were talking tonight a lot about endocrine disorders in class, but got kind of cut off at the end, so I will recap type 1 and type 2 diabetes. So, diabetes is a metabolic disorder of which there are different forms. So you have type 1 diabetes, type 2 diabetes, gestational diabetes, for example. So what we want to talk about first is why insulin is important, okay, where it comes from, and then what happens in people who have type 1 versus type 2 diabetes, where there are some similarities, and then where do the differences lie in terms of treatment. So when we talk about insulin, we have to talk about why is it important. So insulin, remember, comes out of your pancreas. And we know that it's important to control blood sugar, but how does it control blood sugar? That's what's important. So here's your cell, right? And then here's your blood vessel, okay? You have glucose. So we eat, we digest, break it down. Now we've got glucose in our bloodstream, but ultimately we would like the glucose to go into our cells where then it can be consumed for doing cellular respiration, right? So the problem here is that your cell has a fatty membrane. Glucose, as you know, if you've ever made Kool-Aid, is water soluble, and so you can't just push it through the membrane because it won't be able to pass through a fatty membrane because it dissolves in water, not fat. So now we need to put in some sort of channel or transport mechanism to get it from point A to point B. So we use a glucose transporter. It's sometimes written like this when you read it in a textbook. That's going to help transport the glucose from the bloodstream into the cells, and that'll be consumed. The problem that we have with some of our glucose transporters, or different subtypes, is they are dependent on insulin. So what I mean by that is, in order for the glucose transporter to operate, it is dependent on insulin assisting with that operation. So if you don't have insulin, it's almost like the door that's going to open to allow glucose into the cells is snapped shut. So now the glucose stays in your bloodstream and not in your cells. So that's going to wind up with you having hyperglycemia associated with diabetes. Hyperglycemia simply means hyper, it's too high. Glycemia refers to the level of glucose in your bloodstream. So you have high glucose in your bloodstream. Now, your cells still need to eat, right? They still need something to keep them going. And so we've taken glucose off the table, so now we have to have something else, right? So your cells are going to start to break down protein and fat as an alternative because it's not picky. It can break down protein and fat for energy. We all know that. So in doing that, what you will generate are substances called ketones that are involved in the metabolism of protein and fat. Ketones will accumulate in the bloodstream, and that causes a condition called diabetic ketosis. And one of the outcomes of that is that you'll have a decrease in blood pH. Your blood becomes increasingly more acidic, which is dangerous, needs to be addressed. Okay, so now that we understand why insulin is important, let's talk about the different types of diabetes. So, if someone has type 1 diabetes, it means they have no insulin. Okay, they had it at one point, but not anymore. Okay, why do they have no insulin? Because the beta cells of the pancreatic islets have been destroyed. So, how did that happen? It's thought that type 1 diabetes is largely autoimmune. Now, it can be idiopathic and it can be linked to a viral infection, but it is thought that most cases of type 1 diabetes are autoimmune in nature. What does that mean? That means that we're producing autoantibodies. And those autoantibodies in this case are selectively wiping out the beta cells. If you don't have the beta cells in place, you can't produce insulin. And that's where the origins of type 1 diabetes comes from. Type 2 diabetes is is different. People who have type 2 diabetes theoretically can still make insulin. So it's a form of diabetes linked to insulin resistance. Only about 5 to 10% of all diabetic patients have type 1 diabetes, so 95% of the cases are attributed to type 2 diabetes. Type 2 diabetes is related to insulin resistance and insulin deficiencies long term. Okay, so these patients at one point did make insulin and probably in most cases can still make insulin. So what is their issue? It can be that they have a defective glucose transporter. Okay, so that can be one thing. Or one of the other reasons is you can have downregulation of the insulin receptor. And when a receptor downregulates, what that tells me is we need more insulin to get the same effect. Okay, so because of that, the insulin that that patient is producing is no longer adequate for function in terms of getting the glucose from the bloodstream into the cells. It's just simply not enough of it available. Okay. When someone has diabetes, there are certain signs and symptoms connected to it. And then I'm going to talk about markers that are used to assess where you are on the scale for diabetes in terms of A1C, which is a marker that we use more for type 2 diabetes and not type 1. Obviously, for type 1 diabetes, one measurable outcome you could look at is looking at the autoantibodies, right? You would test positive for those. Okay, some of the symptoms associated with diabetes would be polydipsia, polyuria, and polyphagia. All right, so what polydipsia tells me is that you have continual thirst and drinking. Polyuria tells me you have constant urination, and polyphagia that you have tells me you have constant hunger. Remember, phage means to eat. So why do you have polydipsia? Well, if we have our cell, right, and we have a lot of glucose out here, and we don't have any in here, remember? Cells have water, and so does their extracellular fluid have water, but they need to be in nice, happy osmotic balance. Well, now you're throwing a high level of this particular molecule on kind of the wrong side of the track, so to speak. So to balance out osmotically balance on both sides of the membrane, we have to draw water out of the cell to kind of dilute out that high level of glucose. If you're doing that, your cells, from their perspective, right, are losing fluid, and so they're dehydrated. So that's going to account for this. If you have constant thirst and drinking, it's going to be connected to the fact that you're constantly going to be urinating. In addition, glucose acts almost as an osmotic diuretic on the kidney. Polyphagia means that you're going to have constant hunger, and the reason for that is your cells, because they can't consume glucose, are sending out a signal that they are in a state of starvation. And again, that's one of the reasons why they're going to start breaking down fat and protein and generating ketones connected to diabetic ketosis. So these are some of the signs and symptoms. In addition to that, you would have, you could quickly assess it looking in the urine for the presence of ketone bodies and for the presence of glucose, which would be indicated on a regular test strip that you would use to do urine analysis. So how do we treat it?
It's open if you guys actually want something.
Obviously, if someone has type 1 diabetes, because they have no insulin, the thing we need to give them is insulin. Okay, so how can insulin be administered? It's administered subcutaneously, right? The old-fashioned way is you would do kind of the manual tester. Prick your finger, put on a little glucometer, it'll tell you your current blood sugar, then you adjust the amount of insulin that you need depending on your blood sugar in anticipation of the fact that you're going to eat. So you give yourself the insulin before you eat, then you eat, and the insulin is available to then lower your blood sugar, right? That's the old-fashioned way. That's the way my in-laws still do it. Many people now have a pump that kind of does all that manual labor, or much of that manual labor. It's kind of in a self-contained apparatus that you can actually load an app onto your phone and track your blood sugar, which is pretty cool. So That's really different types of administering, different modalities of doing it depending on comfort and what works best for the patient. For type 2 diabetes, our issue there is many times the patient doesn't really need insulin, but needs some sort of treatment that's going to get around the fact that they are experiencing insulin resistance, okay? So there are different types of drugs that do different types of things all around the production of glucose sensitivity, the production of insulin, etc. So I would argue one of the first things you'd want to assess as a type 2 diabetic is your diet. You definitely want to control the level of carbohydrate. And for some people that are in a pre-diabetic state, that is enough. Just modifying their diet, watching their carbs, watching their refined sugar is enough to help keep them from creeping up into a diabetic state, which we'll talk about when we talk about A1C. Then you have drugs like metformin. Metformin acts on your liver to control the production of glucose on the front end. It controls a process called gluconeogenesis. It inhibits that process. It also disrupts the absorption of glucose. So that's a second option for some people. That can be combined with other types of drugs that work to do things like delay carbohydrate absorption, for example, or interrupt glucose transport. There's other drugs that are pretty widely used. They're called sulfonylureas. Those will increase insulin production. Some of these are given orally, some of these are given through injection. It really depends. And there are new treatments for diabetes, type 2 diabetes that are coming on the marketplace all the time. In some cases, people who are type 2 diabetics will need insulin as well. All right, so what are one of the markers for type 2 diabetes that's used pretty often that people are familiar with is called A1C. And there is a range of numbers that we're going to talk about. What A1C is a measure of, it's a measure of the amount of glycosylated hemoglobin. So the higher that A1C number is, that tells me the poorer, I guess that's not the right word, blood sugar control you have. So if this number goes up, what this tells me is your blood sugar is not being well controlled. And there's a range, so we go from a scale of 1 to 10. So for example, if you have an A1C, for example, that's greater than 10, that's a problem. So something like 12, okay, that's a problem and we need to address it. If we have an A1C that's, let's say, less than 6 or 7, then we look at that as okay. If you're going over 6 or 7 up until around 9, then we're in a range where we have some concern and some caution, and you might be told you are in a pre-diabetic state. So the lower the number, the better off you are from a blood sugar control perspective. So the incidence of type 2 diabetes has gone up significantly in this country in the past 25, 30, 40 years. There is a link between type 2 diabetes and obesity. It's linked to diet and lifestyle and other environmental factors. It's also thought there is a genetic link. Or type 2 diabetes. And I want to say I'm not blaming it on obesity because you do have patients that are not considered obese. When you look at the cutoffs, right, and the evaluative tools we use to determine that, yet are still in a pre-diabetic state perhaps. They might have a little extra weight on their frame, but they're certainly not morbidly obese. So, you can have type 2 diabetes patients that can get themselves down to physiological normal levels of insulin in some cases where they can come off some of their medications long term. But if someone is a type 1 diabetic, that is a life-threatening, manageable illness. If someone has type 1 diabetes and stops taking their insulin, it is absolutely life-threatening. So they will need medication in the form of insulin for the rest of their life. They will need treatment, okay? If you choose to do nothing about diabetes, or what are some of the outcomes associated with people who don't manage their diabetes? Well, you have things like blindness, kidney failure, right? Renal failure is an outcome sometimes of poorly managed diabetes, issues with circulation, and cardiac issues, to name a few. Some patients with diabetes develop what's called diabetic retinopathy, which can lead to blindness. There are some people who have diabetic nephronopathy, which can lead to renal failure long-term and possibly to the point where you would need a kidney transplant. Oftentimes there's poor circulation connected with some of the cardiovascular issues associated with poorly managed diabetes. This is where you see people developing potentially dry gangrene or have to have amputations of perhaps toes or feet, problems with circulation to the lower extremities. And then there are certainly secondary cardiac issues associated with poorly managed diabetes as well. That's going to do it for our talk on diabetes and our last video for class.